Welcome to the Early Recognition of Sepsis in Long-Term Care conference call. My name is Jenny, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star then 1 on your touch-tone phone. Please note that this conference is being recorded. I will now turn the call over to Donna Thorson. You may begin.
Thank you, Jenny. And I want to welcome everyone. Thank you for joining us for this webinar regarding early recognition of sepsis in long-term care. This is actually part of a Hot Topics and Infection Prevention series that HealthInsight is providing for our 4 states of Nevada, New Mexico, Oregon, and Utah. But this particular one we've opened up to the entire Great 8 region, which is a total of 18 states. So thank you all for joining today. I wanted to introduce myself. I'm Donna Thorson. I'm a senior project manager with Nevada, and the images, the pictures that you see are my teammates across our region. You may see something from them in chat today. We only have one objective for this meeting or this presentation, since it's a very short one, and that is that you'll be able to describe one tool that you could adopt or adapt to use for use in your organization after hearing about the impact of sepsis in our country. I wanted to briefly share with you some critical facts about sepsis to illustrate the magnitude of the problem. And what you see before you is the definition that the Centers for Disease Control and Prevention use to define sepsis. One of the things that's really critical about this is sepsis is the leading cause of death in the United States hospitals. 62% of the people that are hospitalized with sepsis are re-hospitalized within 30 days. And as many as 92% of sepsis cases originate in the community. However, mortality from sepsis increases for every hour that treatment is delayed, and it increases by 8% every hour. And the Centers for Disease Control and Prevention estimate that as many as 80% of sepsis deaths could be prevented with rapid diagnosis and treatment. Just to look a little bit at the cost, financial cost is up here as across all payers, and the most recent data available was from 2013. It is the #1 cost of hospitalizations and rehospitalizations in the United States. But there's also a human cost. Sepsis affects over 26 million people worldwide each year, and it's the largest killer of children, more than 5 million every year. More than 1.6 million people in the United States are diagnosed with sepsis every year, and that's a shocking 1 person every 20 seconds. And that incidence is rising by 8% every year. A total of 258,000 people die from sepsis every year in the United States. That's 1 every 2 minutes. And more than people who die from prostate cancer, breast cancer, and AIDS combined. This is data reported in the Healthcare Cost and Utilization Project, and you can see here that it shows hospital admissions from nursing homes are more likely to be for infections than for hospital admissions from the community. And sepsis is the #1 infection that's reported. Admissions are more likely to be for sepsis than for any other infection. However, keep in mind that sepsis can develop from pneumonia, UTIs, and skin and tissue infections. So it's very important and critical that we're looking at early recognition of signs and symptoms for sepsis in these areas so that we can prevent the cost in human lives. Regardless of whether sepsis or septicemia was a principal or secondary diagnosis, a greater portion of patients with 1 septicemia admission were admitted from a skilled nursing facility. and individuals admitted from a skilled nursing facility were more likely to die during their hospitalization than those admitted from the community or other settings. In 2010, 28% of patients admitted from the skilled nursing facility died during the hospitalization, compared to 19.8% of those admitted from other settings. And this probably has something to do with the more vulnerable seniors that are in skilled nursing facilities, but it also might be something that we can prevent with earlier recognition. So I'm going to ask you now to respond to this polling question. In the past 6 months, have you transferred a resident with signs and symptoms of sepsis to an acute care hospital? And Emily will go ahead and open that poll for us now. This is one of the key areas that our community has been focusing on here in Nevada. And we have a Sepsis Coalition that I'll discuss in a couple of minutes here. But there are efforts, I think, going on across the country. We've had previous presentations here. So please let us know, have you actually had to transfer somebody with signs and symptoms of sepsis to an acute care hospital in the past 6 months? I'm seeing lots of yeses in the chat box. Emily, did you pull up the poll question? There we go. We have about 15 seconds left on the clock for the polling question. Please make sure you respond and submit your answer. And we'll be able to see across all of our participants today how many have actually been impacted by this. All right. It looks like there's been quite a few that have had that. So apparently this is something everybody is definitely interested in. So as I began to share with you, in Nevada, the Nevada Hospital Association about 3 years ago started inviting hospital sepsis coordinators to meet across our entire state and talk about efforts that they are doing to prevent mortality and morbidity in their hospitals. And I became involved as the lead for the skilled nursing facility task force work in our community to see if we could actually engage the skilled nursing facilities to participate. And we have gotten some participation, which has been wonderful. The goal is that we're actually working across all settings to reduce the morbidity and mortality for sepsis. What began for development of this skilled or the toolkit that I'm describing here today is that the HCA hospitals here in our community decided that they wanted to reach out to specific skilled facilities because of the number of admissions they were getting who had a diagnosis of sepsis. And so they looked at their admissions and identified 4 skilled facilities within their referral patterns and reached out to do and offered to do education on sepsis at the skilled facilities. And the goal was that not only would the skilled facilities have a better idea of how to recognize and intervene early with signs and symptoms, but that if they had to transfer somebody from the facility to the emergency department, that there would be communication ahead of time that someone suspected of sepsis would be coming to the emergency department. As part of that, I decided that I would help the skilled facilities to implement something based on the education that was being provided to them. The hospital sepsis coordinators really didn't have an understanding of how the workings of a skilled facility and the regulations that they're under. And that made it difficult to translate how they address what's called their bundles, their 1 hour, 3 hour, and 6 hour bundles for their quality measures. And the skilled nursing facilities needed to be able to translate the actions that that the hospitals take into actions that they could actually take within their resources and their regulations. So, out of curiosity, this is another polling question. Have you been asked by a local hospital to work together on early recognition and intervention for the signs and symptoms of sepsis? I'm going to ask Emily to open up the polling, and everybody take a few minutes to let us know if you've actually been approached by a local hospital to partner with them on sepsis. I don't see the results yet. There we go. All right, so the majority of you have not been asked. We do have a few. So this might be something where you, if you're recognizing sepsis in your facility, might actually reach out to the hospital and ask them to partner with you. So the toolkit itself is located on the HealthInsight website underneath nursing home resources, specifically promising practices to address specific concerns and sepsis. We've included a webinar that was actually provided by the Great Eight that is designed for home health and school facilities. It's an excellent education about sepsis itself. I would encourage you to listen to it if you were able to participate in that one. And then below that, you'll see the sepsis toolkit. The tools are divided into a couple of different sections. We have one on education. There are materials, PowerPoint presentation for education specifically for nurses. A second one specifically for certified nursing assistants. And both of those come with a post-test that you could actually use as a pre-test if you'd like as well, and then be able to provide continuing education credits within your facility if you do that currently. We also believe that the presentation that is provided to the skilled nursing assistants could be used with all the staff in your facility so that they're aware of early signs and symptoms to be able to alert the nursing staff, especially if you use the Stop and Watch tool from the Interact program. There's also educational materials that can be used with the residents and family members. Part of those education materials include an infographic from the CDC that has a visual picture of the different signs and symptoms, and some fact sheets on what sepsis is, how it's treated, and how to prevent it, and a life after sepsis fact sheet for patients that you might have that were admitted that had sepsis in the hospital and are then going to be receiving rehabilitation in your facility and then going home. You can make sure that they have that material to help them pay attention to what's going on in their lives and prevent it recurring since they're at higher risk after they've had it once. There's also a screening tool that includes information on it for the facility nurses, but also for the nursing assistants. And this is a screenshot of what the hospital sepsis coordinators call the ladybug form. It includes in it the vital signs and then the symptoms that the CNAs would be looking for so that they would know to alert the nurse. This flow chart was created to follow the same structure as the care paths in the Interact program. It includes the use of the stop and watch tool. It begins at the top left-hand corner with signs and symptoms that the staff should be paying attention to, and then indicates that the CNA should be taking, if they recognize any of those, should be taking their vital signs, looking for the systemic inflammatory response syndrome, or SIRS. If they don't meet any of those criteria, it indicates for the CNA to complete the stop and watch, and if they do, they are immediately to go to the nurse and alert the nurse so that the nurse can do an assessment as well as notify the physician that they suspect a resident might have sepsis developing. Once the nurse completes their assessment on organ dysfunction, there is again an S-bar notification to the physician about what the findings were and relates to the sample nurse-driven protocol that we have for sepsis. This protocol was developed just as a sample and a foundation. It is not the entirety of what probably needs to be included. Both the flowchart and the sample protocol were developed with the assistance of a nurse practitioner, physician, and an RN so that we could capture the basics. So it includes on the protocol the purpose of having it, the definitions of what's being looked for, and it incorporates the expectations of what should be communicated to whom and by when. As I mentioned before, there's support for the patients for after discharge so that they understand the impact of what having had sepsis is in their lives, because there are some challenges often with recovery, and they need to be more cautious about contracting another infection. It talks specifically about what they can do to prevent a recurrence. And to go along with that, we adopted a tool that was shared by the Texas Medical Foundation, adopted from another organization. I can't read it from here, but I believe it's Southern Healthcare. This is a stoplight tool with the red, yellow, and green zones that we're probably familiar with for like heart failure and COPD. But it goes through the signs and symptoms of what the patient should be looking for as far as their health and when they should contact a healthcare provider so that they can prevent the recurrence of sepsis. And you can see the back side of it actually has on there a plan for preventing infections at home so that the nurse or social worker can go over this with the patient before they leave your skilled facility to return home and prevent that 30-day readmission that now impacts on your value-based purchasing. I wanted to share with you a wonderful success story that we've had here in Nevada. This facility, skilled facility, Silver Ridge Healthcare Center here in Las Vegas, was part of the Covenant Care organization, and they were one of the facilities that received education directly from a hospital sepsis coordinator in their facility for their nurses. What happened as a result of that, the director of nursing was very much motivated to try and do something about this. They are participating in a specific program to reduce potentially preventable hospitalizations in our state, and so they have a secondary motivation for participating as well. And so I talked with the director of nursing about what they would probably need to help them, and they talked about tools that they could use with their staff, education for their staff, and developing a protocol. So I worked with the hospital sepsis coordinators and was able to get the PowerPoint presentations from them that they were using with the skilled facilities, as well as one for the CNAs that was being used in the hospitals, and that became part of our toolkit. We also worked, based on what the suggestion was, to make sure that there was materials available to use for education. So that infographic from the CDC is a really good tool that can be put up and as a prompt for their staff. I participated in, I was particularly concerned about the family and patient education because I had been involved with a family member at another facility in our state that was doing a big campaign about recognizing sepsis to stop death. And this woman said to me, I have no idea what sepsis is, and I don't know what I'm supposed to do to stop it. So that made me feel like I needed to include in the toolkit education for the family so that they were aware of what it was and the dangers and how they could prevent it. So that kind of rounded out our toolkit. I shared that with the director of nursing and their regional clinical coordinator, and they took those tools back to their corporation, and actually it took quite a while for them to do this because, as you can see, they integrated it into their electronic medical record. It took them almost a year to be able to do that. But once they did that, it was implemented across their entire corporation in the country. So if you have you are a Covenant Care facility, you most likely have seen the laminated flow chart because that was adopted for all of the nursing homes. The corporation laminated them and distributed them across the country. And then the electronic medical record sepsis protocols went into effect, I believe, in May. And so what we found out is that within the first month, the protocol was actually triggered 4 times in this facility, and they were able to keep 3 of those 4 residents from having to be transferred. The 4th one had multiple comorbidities that made it difficult for them to care for the resident in the facility safely, so they did transfer them. And then as an update, by the end of August, they actually had used the sepsis protocol 14 times and successfully treated 12 residents, avoiding that hospital transfer. And we're all aware of, how difficult it is for residents when they're transferred, but it messes a little bit with their cognition. Even if they don't have dementia, it still kind of throws everybody off a little bit, and it puts them at higher risk for more infections being in the hospital. So this to all of us here in our state has been a tremendous success, and we're now working with other skilled facilities to try and get this implemented in their facility. So having gone through this, I now want to ask all of you to look at this poll question and see if there's one of these areas that you believe you could adopt or adapt for use in your facility to increase the early recognition and intervention for signs and symptoms of sepsis. So Emily, would you please pull up the polling question? So the Sepsis Coalition, while we're waiting for this to finalized here, the Sepsis Coalition is actually starting to engage our emergency medical response system, and we have one EMS provider that is actually implementing their own sepsis protocol and working directly with a facility to do a pilot on implementing the sepsis protocol transfer as they're going through and doing an alert with the emergency department to improve the treatment for the residents in a timely manner. Let's see what the results say here. Oh, good. Education is a great idea. Between the webinar that's up there and then the slides that are available, you can use either one or both for your staff. So please reach out to your quality improvement organization if you want any further support for it, or download the toolkit from our website. This is just a reminder of where you can find these materials on our website. And this presentation is actually being recorded and will be made available under our hot topics in infection prevention, probably within the next 2 weeks. In creating this slide set, these are the two resources that I used for the data from the Healthcare Cost and Utilization Project. And so now we'll open it up for any questions.
Thank you. If you have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone. And we have Don Smith from Lynn Haven.
I was just wondering if we could go back to the slide that shows the website that we can go to for resources.
Absolutely.
Perfect. That one. Thank you.
You're welcome. I see that there's a question in here from Jim Peterson about the sepsis program integrating with antibiotic stewardship. And that is actually something that we are trying to address specifically because that has come up repeatedly. We are planning to actually provide education to the nursing homes on antibiotic therapy optimization because the guidelines for the length of time for antibiotics to be provided based on the infection has changed a lot from the standard 10 to 14 days. So I think that will be part of it. The other piece that has been addressed in this whole thing is getting the blood cultures and starting them on a broad spectrum antibiotic, but then having a time out for the antibiotic when the results of the culture come back. I hope that answers your question a little bit, Jim.
And we have another question from Marla Prozowski from Good Samaritan.
My question was also, is it related to the antibiotic stewardship and decreased use of antibiotics? Thank you.
You're welcome. And the other resource slide, is that the data one? Oh, there you go, Ashley. So feel free to reach out. If there's any questions that you have, I'm available. Your contact at your quality improvement organization is also quite capable of supporting you in this work. And we all convene and talk with each other on a regular basis to share resources. So we are all here and available for you. My contact information is on one of the slides that's available, and the handouts were provided to your quality improvement organization, so you can reach out to them. As we close, I do want to remind you that there is going to be an evaluation that will come up. Please take the time to fill that out so that we know whether or not we're meeting your needs as a provider to our residents. We want to definitely provide the things that you need. And I believe, unless there are any other questions, that will round us up for today.
Thank you, ladies and gentlemen. No other questions.
Excellent. Thank you very much. I appreciate everyone taking the time to be with us today.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating.